So our next speaker is Akash Gunjan, and he'll be speaking about rational-based repurposing of drug combinations for topical and intralesional keloid management and in vitro study.
All right, thank you. I think I'm going to stand over here and then try to use the laser pointer here. Okay, yeah, we can see the pointer now. So hello, everyone on Zoom as well. So even though the title says topical and intralesional keloid management, I don't see why some of the things that I'm going to be talking about cannot be used for systemic therapy for the extensive keloids that we have seen. And in fact, combination therapy of the type that I'm going to be talking about is probably the way to try systemic therapy. All right, so we all can agree on the fact that, there are not too many effective therapies available for many keloid patients, and new therapies are urgently needed. The problem with developing any new therapy is just the fact that it takes a long time and a lot of resources to find new targets and then to find new drugs that will target those. And typically, it takes at least a decade or more to get any new drug through the FDA approval process. So in the US, that's a huge bottleneck, and I'm sure it's a huge bottleneck at other places as well. And a lot of different therapeutics have been tried and tested, typically as monotherapy in experimental ways for trying to treat keloids, especially ones that are recurrent and that are refractory. But combination therapy is still an underexplored area when it comes to keloid therapy. So this presents us with an opportunity, and that comes from the fact that we already know of a number of different pathways that are aberrant and drive keloid pathogenesis. And even more importantly, after with about 2,000 odd FDA-approved drugs, when we dig into the literature, we find that at least about 60, and maybe the real number is closer to about 100, do have different antifibrotic activities associated with them. These are already FDA approved. So that presents us with a really nice opportunity to try and see what can be done in this space by combining some of these drugs that exhibit antifibrotic properties. So that's my purpose over here. That's what we've been working in a lab for the past couple of years, trying to test some of these FDA-approved drugs that have antifibrotic properties in different combinations to try and find which ones synergize with each other, which ones are safe, which ones can be used intralesionally, which ones can be applied topically maybe. And this is what I'm going to spend the next few minutes talking about. So I'm going to start out by talking about some of the drugs that you're already familiar with, which have been used in monotherapies or maybe in combination with one other drug, something like the 5-fluorouracil and so on. And I wanted to start out with this, and then we are going to talk more about some of the drugs that you might be less familiar with. So this is a typical setup of how we do most of our experiments for screening of these antifibrotic drugs. We start out with primary patient-derived keloid dermal fibroblasts. We grow them in vitro. And then we typically will titrate the drug on them individually until we find a concentration of the drug that will basically prevent 20% of this keloid fibroblast from growing. So it's not by chance that we are getting these concentrations to do this. It's because we specifically pick that, because if we pick a drug concentration that stops 20% of the keloid fibroblast from growing, then we can then observe additive and synergistic effects when we start combining more than one drug. So that's the reason why we picked this. So as you can see, we've got minoxidil over here, which is a component of hair growth formulas, FDA approved for applying to your scalp for growing hair, typically for male pattern baldness. Then we've got the non-steroidal anti-inflammatory drug diclofenac over here. That is not very different from celecoxib. It's in the same class of drugs. We've got a good friend, triamcinolone, over here. And we also have another good friend, 5-fluorouracil, over here. Many of these drugs have been around for decades. They have well-established safety profile. So this is where we want to start. So As soon as we start combining any two of these drugs, you can see that you see an additive effect right away. You start combining three drugs. Any three drugs starts giving rise to the same type of additive effect. We can go up to 4 drugs. And once you get to 4 drugs, you wiped out nearly 80% of these keloid fibroblasts. And I'll show you later that it's not just stopping the proliferation of these keloid fibroblasts and slowly killing them off, but it also very effectively and very quickly blocks the production of profibrotic proteins such as collagen, smooth muscle actin, and so on and so forth. And I'm going to show you some data about that. So these are drugs that have all been tested with monotherapy with limited success in treating different kinds of keloids. Have not been tested that much with the exception of triamcinolone and 5-fluorouracil. So these can be now combined together, and we think that they will be fairly safe. But that is where you guys come in. It's my job to tell you about which drugs you can combine, and it's your job to test them on patients and then tell us whether it worked or not. So you still have the harder job. What about some of the newer drugs that have antifibrotic properties? We have been talking a little bit about different tyrosine kinase inhibitors. Afatinib is one of those in that family. It's an EGFR inhibitor. Another drug that exhibits antifibrotic activity is artesunate. It was originally derived from a plant. It's an anti-malarial drug, and this also blocks signaling. So all of these block specific signaling pathways that are known to contribute to keloids. So I'm not going to tell you more details about the pathways because every drug affects a slightly different part of the pathway. I'm just going to show you a couple of these just to kind of introduce the drugs. Some of you may be familiar with disulfiram, that's shown over here. It blocks the PI3-AKT-mTOR pathway. This is a drug that was developed and is FDA approved to stop people from consuming too much alcohol. So this was given to alcoholics to help them become de-addicted to the drug. Another drug that some of you may be familiar with is empagliflozin. It's a SGLT2 inhibitor. People with diabetes get that. This helps them excrete much more sugar through their kidneys. Normally, the kidneys absorb the sugar. This allows the kidneys to excrete the sugar. But it also turns out to be a very effective sodium hydrogen exchange transporter inhibitor. And that allows it to reduce calcium fluxes through the fibroblasts. And fibroblasts absolutely need high calcium fluxes in order to become activated and maintain their state. So the last of these that I'm going to show you are statin drugs.
We lost the microphone. I'm sorry. Maybe the
other one.
use the one that's on the stand.
It's low on.
Sorry.
Yeah. Okay, thank you.
Heard us.
The one that is underneath the other one. This one is low in battery.
Where's the other one? This. Oh, so
It's not a
does it work?
It works.
Yeah, it's on. Yeah, it's on. All right, thank you. Can you hear me? Yeah. All right, great. The last of these drugs that I'm going to introduce is our statin drugs. Among those, simvastatin particularly has been looked at closely in monotherapies for different types of fibrotic conditions. And this, again, blocks multiple pathways, especially preventing epithelial to mesenchymal transitions, endothelial to mesenchymal transitions, and so on. Activation of fibroblasts, it tries to maintain fibroblasts in a quiescent condition, and so on. And again, when that activation happens, it can eventually contribute to tissue fibrosis. Okay, so let's look at what some of these drugs yes, eventually. Yeah, because you need the fibroblasts to be activated to contribute to tissue fibrosis. Yeah. So, so here's a look at afatinib, artesunate, the anti-malarial drug, disulfiram, the alcohol de-addiction drug. And when we start combining, we start seeing similar effects. And I threw this piece of data just to keep John happy here. Radiation, when combined with any one or multiple of these drugs, always has a synergistic effect. So the orange bars here are radiation, the blue bars are the drugs alone, okay, without the radiation. So as you can see, 2 to 3 drugs start having additive effects here. Now, what about synergistic effects? So let me give you an example of that over here. So we've got untreated over here. We've got celecoxib over here, empagliflozin over here, pelopidine over here. Celecoxib plus EMPA, not particularly additive even, but when we combine celecoxib with felopidine, you see a strong effect. That effect is about as strong as when we combine 4 drugs over here. So clearly certain drugs seem to have very strong effects, and those are the ones that you would want to prioritize. And keep in mind that we're using extremely low concentrations of these drugs to get these effects. So far I have only shown you the effect of the drugs on patient-derived keloid cells. Well, what do they do to normal fibroblasts? So here in blue is keloid patient-derived fibroblasts from patient A, and orange is normal fibroblasts from the same patient acquired from normal adjacent skin. And as you can see that for some of these drugs, like for example, triamcinolone, which is the corticosteroid, you see almost no difference between the effect of the drug on normal fibroblasts versus the keloid fibroblasts. But for other drugs like empagliflozin or felopidine or simvastatin and even verteporfin, verteporfin, by the way, is an inhibitor of a downstream member of the same pathway that is activated, the mechanosensation pathway that is activated by piezo-2. The downstream effector is the YAP pathway. This drug, verteporfin, blocks that pathway. So piezo-2 is the one that Prema talked about a couple of days ago. So you can see that some of these actually make the normal fibroblasts grow a little faster. I don't know if that they really will grow faster in vivo, but in vitro they do seem to grow a little bit faster in some cases. In some cases they're unaffected, but clearly it does attenuate the growth of the keloid fibroblasts. And that's not surprising because these pathways are particularly activated in the keloid fibroblasts, but they're not activated in the normal fibroblasts. So to kind of combine a lot of these, so I said there's at least 60 drugs that I have identified by looking through the literature, and the real number could be about 100. We've screened maybe about 30 of those. It takes time to screen them the way we do it. And in general, if we combine data from a lot of these drugs, we can say that if we just treat with a single drug, you get about 80–85% effect. Double drugs, about 60. And this is just looking at the proliferation and the survival. Yeah, that's cell viable. What was that?
You said if you use single drug, you see 84% efficacy.
No. So this is survival. So remember we pick concentrations that only will kill about 20% of the cell or block the proliferation about 20% of the cells, because that allows us to look at their additive and synergistic effects. So the point that we were trying to make, yeah, we should have probably done it. Yeah, the other side, yeah. So what we should have said that, when you start adding them, they are much better at blocking the pro-fibrotic activity as well as proliferation of the fibroblasts. So it's kind of counterintuitive a little bit over here. So we've also gone in and actually looked at the effect of different single, double, or triple drugs. And you can see that these were all cells that were treated for either 7 days left untreated, or treated with a single drug, treated with 2 drugs, or treated with 3 drugs. And over the same period of time, you can see the drop in collagen levels. You can see the drop in alpha smooth muscle actin over here. You can also do the same experiment rather than immunofluorescence. You can do it by Western blotting, and you see the same kind of effects over here. And so overall, we are not just stopping or slowing down the proliferation of these keloid fibroblasts, we are actively stopping the prominent pro-fibrotic proteins from accumulating in these cells and being secreted by these cells. So these days, of course, you haven't really done anything unless you've done some single cell RNA sequencing. So we also perform that to see what else can we learn about what is really going on when we treat these cells with these combinations of drugs. So once again, we've got, this is from patient 9. These were the proliferating untreated keloid fibroblasts. And again, so in this case, we are not looking at 9 different populations of cells. These are the same keloid fibroblasts from the same patient. And in those, based on the transcriptional profiles, we can establish 9 distinct transcriptional states in there. So it is not very different from looking at different cell types, performing the same kind of experiment on a bunch of different cells and identifying them based on their transcriptional profiles. But this is all within the same cell type, just different transcriptional states. And I'll show you in a minute that, upon treatment with 3 different antifibrotic drugs, you can see that the pattern changes quite significantly. And what kind of changes we see is kind of summarized in the next slide over here. So how do the untreated cells compared with the treated cells? So you have a high inflammatory signaling state in the untreated keloid fibroblasts, and that gets greatly reduced in the treated fibroblasts. You have strong ECM production. That ECM production goes down in the treated. You have lots of actively proliferating keloid fibroblasts. They get reduced upon the treatment. You also have high levels of ECM remodeling enzymes present in the fibroblasts initially. After treatment, they go down quite considerably. So both by single-cell RNA sequencing, looking at protein biomarkers and so on, we can establish that these drugs, when combined together, are indeed having a strong antifibrotic effect, and we can tap into these effects to come up with better modalities for treating keloids, both refractory, recurrent, and so on. So how do we take all this in vitro data and try to make it into a form that can be used in the clinic? So there's a method known as quantitative in vitro in vivo extrapolation, where you make certain assumptions, use certain parameters, use basically everything that is known about that drug, including its half-life, whether it has a depot-like properties and so on. And you feed all of that into a mathematical model, and you try to come up with what types of concentrations you might be needing, or what kind of dosages you might be needing to use the same drug in vivo in a human patient. And these numbers are kind of listed over here. So the concentration that we're showing over here are the low concentrations, because that's what you would need if you were planning to use them in, in combination therapy. So this is a concentration that will kill off 20% of the cells, of the keloid cells. And so you'll see a lot of them are really low doses, like 0.1 nanomolar. So that's 100 picomolar. So very low concentration. So how much do you need in milligrams? Well, a lot of zeros. So this is way, way, way lower. So let's look at some of the familiar drugs. So how about 5-FU? So the concentration that we need in vitro is 50 micromolar. That roughly corresponds to about 0.4 milligram per cubic centimeter, which is not that far away. I just realized that you use at one milligram per centimeter, right? So Michael uses it at 1 milligram per centimeter. So this modeling is telling us something real about that these values can be used as a reasonable starting point in the clinic. And so which is good to see that, for some of these things, we can actually correlate the actual clinical effects at that dose. So the drugs, in vitro concentration listed here, suggested in vivo concentration are listed here. And so these are the drugs that we think can be combined, up to 3, 4 maybe, for topical applications, and they are just listed in alphabetical order. I am not making a suggestion that this is my favorite 3 or my favorite 4. Like I pointed out, in the vast majority of the cases, you combine any 3 or 4 of these, they have very similar effects. There are some that are clearly synergistic, but we want to follow them up some more before we make the determination that, yes, this is absolutely the best combination to move forward with. So hopefully next time we'll get to talk more about that. We've also got some additional drugs that you can, we think that you can inject intralesionally, artesunate, mitoxantrone, and verteporfin. Verteporfin is the one that works on the piezo2 pathway. So these are the drugs, and so once again, the concentration or the doses that you're going to need in vivo are very, very low. They are typically at least 50 to 100-fold lower than the lowest dose that have ever been used in the clinic. So my general feel is that for keloid therapy, for intralesional keloid therapy right now, a huge excess of drugs are being pumped into the patients. And that is why there are a lot of adverse effects. And I think they can be minimized to a great extent simply by reducing the dose without reducing the efficacy. So my conclusions, we have a long list of drugs that we can use to treat keloids in patients by simply repurposing FDA-approved drugs off-label for off-label use, either topically, intralesionally, or even systemically. I would just recommend using very, very, very low doses compared to what people are using currently. And we can be smart about this. We can, if we pick drugs that typically target 3 different pathways and combine them together, typically they result in synergistic effects. You're blocking 3 different pathways that independently contribute to keloid formation. So this is what you would expect. Another advantage of using multiple drugs is the fact that it will be very hard to develop drug resistance. Cells will not become resistant to multiple drugs all at the same time. And because we've got a long list of drugs now that you can combine. If a 3 or 4 drug combination doesn't work for a patient, you just go to the next 3 or 4 drug combination because they seem to be very, very similar in their properties and in their effects when you use them in combination. So if one combination doesn't work for a patient, you would at least have about half a dozen other combinations that you can try on that patient. And because none of those drugs will overlap, there's a good chance that one of those combinations will work for the patient. So I want to stop there and acknowledge the people who did all this work. This work was started by a former PhD student, and that has been continued by my current PhD student, Nina, shown over here. She's going to give the last talk of the day today, so hang around for that. And with help from 3 medical students, Alexandra, who graduated earlier this year, Kendall, who worked on the project last year and is a 3rd-year medical student, and Jasmine, who's working in the lab right now. So they all contributed to these studies. Thank you.